Hello, everyone. I hope you can all hear me. Welcome back to the Health Studies User Conference for the second session, where we will hear presentations from speakers who have submitted their work using data from the UKDS. This is the first of two paper presentation sessions on mental health. Mental health was a popular topic this year and what we received the most abstracts on. This session will look at mental health broadly, including 4 presentations covering mental health in midlife among young adults and the effect of geography, comparing the mental health of coastal communities with inland communities. So on to the first presentation. So I'll give a short introduction to the speaker. So we have Martin Danka. Martin Danka is a PhD candidate at the Centre for Longitudinal Studies, UCL, funded by the ESRC, BBSRC, SOCB Centre for Doctoral Training. His research focuses on the relationships between mental and physical health, including the role of the social environment. And we're going to hear about his talk on the health consequences of psychological distress in midlife, a longitudinal outcome-wide analysis on the 1970 British cohort.
Perfect. Thanks very much. So hi, everyone. So as mentioned, I'm based at the Center for Longitudinal Studies, and today I'll be presenting a study that's part of my PhD that focuses on the health consequences of psychological distress. And I'll share some preliminary results from analyses of the self-reported health outcomes. And I also wanted to mention that this project, as well as my PhD, are supervised by Dr. Richard Silverwood, Professor George Plobidis, and Dr. Jess Bone. So first of all, I'd like to briefly discuss the concept of psychological distress, because it's a term that's often used, but not always as clearly defined. Psychological distress can be understood as a general state of emotional discomfort, which can include non-specific symptoms of psychological stress, depression, and anxiety. And from a clinical viewpoint, it is common to think about these specific symptoms as separate, but in population research, we may also be interested in capturing the broader shared experience of emotional suffering that is common to these constructs and that is referred to as psychological distress. Importantly, psychological distress has been linked to a wide range of adverse health physical outcomes, and it's also very costly for the economy. When thinking about psychological distress and how it affects physical health, there are 2 broad pathways. One of them involves direct physiological pathways, where distress can lead to hormonal and other biological changes, and these can in turn contribute to poorer health over time. But people can also change their behavior when feeling distressed, and these behavioral changes, like reduced physical activity or unhealthy eating, can also impact health. And of course, these 2 pathways interact with one another, and much of recent research has focused on the specific pathways and trying to sort of untangle these mechanisms. But when we take a step back and ask how psychological distress affects physical health, there are many ways in which we could attempt to answer this question. So one approach that is sometimes used is to look at overall measures of health. That can be something like self-rated health. And this, of course, has the advantage of capturing many different aspects of health in a single measure, so to make sure that we're not missing something that a person perceives as important to their health. But there are also some limitations, of course, which is that 1, we don't know exactly what's being averaged, and 2, is that because overall health can also include mental health, in a way we might be measuring the effect of mental health on mental health. Another approach is to look at individual health conditions, and this usually means running a separate study for each condition. So this can be sensible when we're interested in specific outcomes, but it can also make it difficult to compare the effects across conditions because studies will often differ in their populations, methods, and the type of effects that they focus on. And the last approach that I'll mention is the outcome-wide approach, where we examine many different health outcomes within the same data set. And the key advantage of this approach is that it allows us to estimate the effects in the same population over the same time period, and we can use consistent methods and similar assumptions across the outcomes, so we can more clearly compare the effects. And in fact, studies like this have a long tradition in epidemiology, and I think we've all seen many examples, perhaps of other topics. But analyzing many different outcomes at once brings its own challenges, and it's only relatively recently that these types of studies have been placed within formal causal frameworks. There's a guideline from 2020, and so as you can see, that's relatively recent, and so previous studies haven't really used this template. There are some existing outcome-wide analyses looking at psychological distress and disease onset, and the most recent one that I'm aware of found prominent links with hospital admissions for endocrine, musculoskeletal, and circulatory conditions. And there are several others, which I think for some conditions there was agreement, like cardiovascular disease, but for others the findings were more varied, and also these studies used quite varied disease categories. So why do another one? There are some limitations of the existing outcome-wide analyses. One of them, which is most of them were cross-sectional, and also most of them lacked explicit causal reasoning. So the causal structure wasn't clear. The effects weren't clearly defined always. A lot of the times there were missing variables like socioeconomic factors, which might be very important. And also some of these studies may have over-adjusted. So adjusting for something like health behaviors that might have happened after the exposure, which can actually introduce bias rather than reduce it. And some selection issues. So in some samples, it's very difficult to deal with selection into the study and then recover the unbiased effect. Another source of variation is reporting, because health outcomes can be either self-reported or drawn from medical records. And this, of course, raises an important question, which is how well do these sources match? And so far, research shows there's considerable variation across different conditions. As you can imagine, agreement can be higher for conditions with specific and well-defined symptoms, so something like diabetes. But even then, I would say that the overall picture is a bit pessimistic. So for example, this is an analysis of the English longitudinal study of aging that found that over 50% of participants who had experienced a stroke, heart attack, or cancer failed to report them. That said, medical records are not perfect either, so they can be affected by other types of bias. So for instance, there can be some underreporting due to limited access to healthcare. But also for some conditions, there can be omission of symptoms that are seen as less serious. So for example, something like acne may not make it to the medical records of a person. So at the moment, we don't fully know, we don't really understand the differential effect of psychological distress on different health outcomes. And we also don't understand how these effects differ when using self-reports and health records. So in line with these gaps, we wanted to estimate these effects, and we focused on midlife, partly because that's what we have in the data set, but also because in midlife, chronic health issues become more common. And then the second aim of our study was to compare the effect of psychological distress on physical health outcomes when the health outcomes are sourced from self-reports and from electronic health records. We used data from the 1970 British Cohort Study, which follows a large sample of individuals born in a single week in 1970 across England, Scotland, and Wales, which Richard introduced earlier. And the study also includes linked hospital episode statistics, so that allows us to run the analyses using both self-reports and HES data. The analyses using the HES data are still in progress, so for the rest of the presentation, I'll mainly focus on the self-reports and the preliminary results from that. The target population of BCS 70 changes dynamically, so the study aims basically typically we would aim at those who were alive and residing in England, Scotland, and Wales at a given time. But we also wanted to have comparable target populations for the self-reports and HES analyses. So to do that, we first included all members of BCS 70, and these people had to be eligible for linkage. And this was defined based on the HES data as having to have lived in England during the eligibility period, so at any point between 2000 and 2012. And as I said, the participants had to remain alive, and we excluded those who emigrated by the end of follow-up. And there were no other requirements regarding missing data. All missing data were handled using structural multiple imputation approach, which I'll mention later. As for the exposure, this was psychological distress, as mentioned, and psychological distress was measured at age 34. And in BCS 70, this is assessed using the 9-item version of Mali's inventory. And there's a lot of previous research on this scale, especially in the CLS cohorts, which shows that the scale should capture the same underlying construct consistently across time and gender in the British birth cohorts. And these are the self-reported health outcome categories. And out of these, we only include those with more than 1% of new cases between age 30 and age 42. This is to avoid data sparsity issues because we wouldn't be able to, for example, adjust for all confounders. This was true for most of them, except for chronic fatigue syndrome and convulsions, fits, or epilepsy. So those could not be included in the analysis. And as you can see, the most common health conditions were chronic back issues, hay fever, digestive issues, and migraines. And you might be surprised to see that the new cases were defined between the age of 30 and 42 instead of age of 34, which was when the exposure was taken, and I'll get to that in just a second. We use the causal diagram with supernodes to represent some of our assumptions about the causal structure. And you can also see that we labeled the age when certain variables were measured. This is just to make it easier to follow. As potential confounders, we included past health conditions, health behaviors, socioeconomic variables, cognition, and developmental factors. And as I mentioned, you might be surprised that these are mostly sourced from before baseline. And this is to avoid over-adjustment bias. So when psychological distress and health behaviors are measured at the same time, it's really difficult to tell what happened first. And if it goes the other way around, then adjusting will introduce bias. And there are also some confounders that were unmeasured, which we depicted in this diagram, being diet and inflammation. And there might also be other ones that are not shown in this diagram. And that's always the case with observational research, though we think that, for example, with the ones that are depicted, there's a lot of other health factors and health behaviors that presumably the residual confounding purely from these factors independently of everything else would be quite small, if any. But of course, it's always nice to show that, and it would be better if we did have the data and if we could show that. We were interested in the risk ratios, which were estimated using modified Poisson regression, and missing data were handled using a structural multiple imputation approach, where we included previously identified drivers of attrition, specifically in BCS 70. To address confounding, we used inverse probability of treatment weighting, and this has some benefits in outcome-wide studies because if we added the covariates into regression models, as is traditionally done, then we would have to specify correctly the confounder-outcome relationship for every single outcome, whereas with IPTW, we could just specify a single confounder exposure model and then apply weights from this model across to all of those outcomes. There was one interesting problem that we ran into, which was that the exposure is a count exposure, and IPTW, there's not much guidance on using IPTW with these types of exposures. So that inspired us to do a separate simulation study on using IPTW with count exposures. We are currently finalizing the results. The approach that I've used for now is the approach that came out as very promising from complete case analysis in the simulations, but it might change depending on what we see with when combined with missing data. These are the preliminary results, and on the x-axis, you can see the estimated risk ratios, and these are rescaled per 4-point increase in Mali's inventory. And that's just a more intuitive way to express the effect. So for example, for chronic back issues, the risk ratio of 1.053 means that a 4-point increase in this stress is associated with 5.3% high risk of chronic back issues. And we chose 4 points because this reflects clinically significant symptoms. So 4 points are sometimes used as a threshold for psychiatric caseness. So just a more intuitive way to express it than just per 1-point increase. And you can see that the strongest associations were found for chronic back issues, digestive problems, migraines, and hypertension. And these are conditions that are closely linked to systems that respond quickly to acute stress. But even for these, the effects are much smaller compared to previous studies. And that might be because the study accounted for a much wider range of confounders and for the missingness procedures, but obviously there could be other reasons. The estimated effects were smaller for kidney and bladder issues, hearing problems, and somewhat surprisingly, diabetes and asthma, though you can see that there's some uncertainty here and the confidence intervals cross no effect. And for cancer and hay fever, the estimated effects were essentially null with fairly narrow confidence intervals. And especially the null finding for cancer aligns really well with previous research, which found that when accounting for many important confounders, the estimated effects of psychological distress on the onset of cancer tends to be very small or zero, except for lung cancer when looking at lung cancer specifically. We also ran some sensitivity analyses, one where we winterized the weights, but maybe more importantly, we also looked at these associations when we don't restrict the sample to those eligible for linkage. And the results were very similar. The effects were nearly identical. And what's left to do now is to finish the simulation study to confirm the analytical approach with missing data. And we are also working on analyses with the HES data, which is still work in progress. And we're also planning some additional sensitivity checks. And there are, of course, important limitations. And I think the main one is that the HES datasets don't include primary data. So this might be more problematic for some conditions than for others. So for conditions that are managed, for example, in primary care mainly, then it might be a bit difficult to compare the findings from the two analyses. Whereas for other conditions that are more measured under specialist care, then that might be less of a problem. There's also limited granularity. So we didn't break the conditions into the specific types. We might do that later on with some of them, but with many of them, there's just not enough cases to do that. And also outcome-wide designs are an exploratory study design. So obviously when you study so many different outcomes, it would always be nice to confirm that with future studies. And also when running so many models, there's the analysis become very complex, and there are some compromises that we had to make in terms of what's feasible computationally. But that could be done if we were only studying a single exposure outcome relationship, for example.
Less than a minute left. Just
perfect.
Thank you. Oh, perfect. Yeah. Sorry.
Yeah, that's right. Yeah. So thanks very much for listening, and I'm happy to answer any questions.
Moving on to the next presenter now, sticking to the timetable. So we've got Sally McManus. Sally McManus is a professor of social epidemiology, director of the Interdisciplinary Violence and Society Centre, and deputy director of the UKRI funded Vision, which stands for Violence, Health and Society Consortium. And today she'll be presenting on a typology of mental health difficulties in young people in England using latent class analysis of data from the 2017 Mental Health of Children and Young People survey. So take it away, Sally.
Marvellous. All right, so I'm going to, a bit sneaky actually, going to have jammed in two different presentations, but I'm going to go at pace, so I promise to get through it on time. But first of all, I just want to say that loads of amazing and brilliant people are involved in both the Mental Health of Children and Young People survey. So that involves Exeter and Cambridge and NatSen and ONS, and also the Adult Psychiatric Morbidity Survey, which I'll mention as well, with people from Leicester and NatSen as well. So but this particular analysis that I'm focusing on today, Valeria Colbus, Neil Smith and Tamsin Ford really key on as well. So the reason I'm cramming into two brief projects is because they're both in response to the mental health charity Mind. And what they came to us saying was that we really want to understand how mental health patterns in the population as a whole. So they're interested in looking at not necessarily just people with a particular diagnosis. They're also interested in people who might have sub-threshold symptoms. They're interested in people who might have combinations of different symptoms. And so they really wanted to look afresh at the population patterning. So this is the kind of thing that is brilliant for our mental health survey series is. So this chart shows some of the different mental health surveys that have taken place over the years, and they're all available on the UK Data Service Archive. So one of the things that I'm really keen to do is to use this analysis to highlight for you how these data can be used in really rich and novel ways. So the boxes that are sort of that nice turquoise colour, teal, I'd say it's teal, they're the adult psychiatric morbidity surveys. And of course, on Thursday, the next survey will be publishing. So 9:30 on NHS England website, have a look, new results. But what I'll be presenting on is the 2014 survey, which is like 10 years ago. And then I'll also say a little bit about the child one as well. Now, APMS, Adult Psychiatric Morbidity Survey, is the worst named survey of all time. It's just England's mental health survey, is brilliant in that it enables you to look at really specific mental health conditions. So for example, if you're interested in serious mental illness, it allows you to focus in on that about 1% of the population who've experienced a psychotic episode in the past year. It also covers a wide range of other mental health conditions. So for example, you could look at the sort of around 3% of people who currently are showing symptoms of drug dependence. So it enables you to look at dependence disorders as well, alcohol, gambling, and other similar dependence disorders. It also includes screening for neurodevelopmental conditions and more detailed assessment for autism as well. So if you're interested in neurodevelopmental disorders, that will be captured in the data. And of course, it covers common mental disorders like anxiety and depression. So that's about 1 in 6 of the population screened positive in 2014 for a common mental disorder such as anxiety and depression. Now, of course, the difficulty with looking at the data in this way is that a lot of people who experience more than one of these, they'll experience some combination of them. And it doesn't capture everybody because some people might be experiencing some of these symptoms, but not at a high enough threshold to be picked up using an approach like this. What we could do is just bung them all together and lump them together and say that actually around 1 in 4, over 1 in 4, have signs of psychosis in the last year, and or anxiety and depression, and or maybe ADHD, and or a dependence disorder. So you could use an approach that simply lumps them together like that. But the difficulty with that is that we haven't got much nuance about the particular experiences that people may be having. So if we look at our population, everybody will be experiencing some different and distinctive combination across these different indicators. So I just want to flag up about the utility of taking a population typology approach, which will enable us to keep some of that nuance, but also produce discrete categories in the population that allow us to understand population profiling. So in our first latent class analysis, we put all of these different indicators in, and we included a series of sub-threshold symptoms, and we included screening for a range of different types of symptoms across, including both serious mental illness, terrible wording, that serious mental illness, it kind of implies other mental illness isn't serious, but using the terminology that we've got, and these range of other indicators that I've listed here. Now, the beauty of a latent class analysis is you tell it, imagine that there is just one class, or that there's 2 classes, or 3, or 4, or 5, or 6, and the program will look for not similar variables, but for people who have a similar pattern across a wide range of different indicators. So it's lovely for profiling the population as a whole. It then groups people together. Now, not everyone will fit neatly and perfectly in because it's a data-driven approach. But what we found using an approach like this is around 6 different discrete groups in the population, which is very useful if you're targeting policies and interventions. Now, the greatest joy of a latent class analysis is you then get to name the groups that come out of it, which many hours are spent in sort of wasted, but ultimately quite enjoyable, finding different sorts of labels that we can apply to these different groups. And, you know, over half the population, hooray, over half the population are actually okay. We called them mentally well. I mean, we could come up with other words, but What was quite interesting is that beyond that 1 in 4 that we got when we lumped everyone together is a big group of people who are really fatigued. They're reporting problems with sleep. They're actually, at this point in the conference, many of you might feel that you belong in this category. But that was a group that had sub-threshold symptoms that emerged. And then about 1 in 4, broadly similar size. We've got an anxious group. They're particularly likely to be reporting symptoms of worry, anxiety, phobias, panic, some depressive sleep, fatigue, but not characterized by that so much. Then a group that was characterized by a much higher severity score across the board. We've got the clinical interview schedule revised. They've got higher levels there. A substance and attention difficulties group, which is more likely to have some of those externalizing conditions. And then the key thing that latent class analysis is so useful for is being able to pick up a discrete group that having a real combination of different types of indicators. Then once you've got a variable like that, you can then use that and describe the profile and the composition of each of these different groups. So that group on the far left, which represents over half the population, very few, only 2% of that group have ever experienced homelessness in the past. I'm just going to move my picture so I can see the numbers, and about 17% in that multiple needs group have experienced homelessness. And likewise, we see a similar distribution for having experienced sexual abuse in childhood. Now, I'm going to plow straight on to a second application of this, and the reason I wanted the first one, I don't need to repeat the methods because you've all seen it now, but this one is using the Child Mental Health Survey. So this is the darker blue ones on the bottom, drawing on the most recent face-to-face survey, which was carried out in 2017. And of course, there have been a whole series of COVID follow-ups, and some of the most recent COVID follow-ups have just gone into the UK Data Service Archive. So do go there, download the data. They tend to draw much more on the strengths and difficulties questionnaire. Now, using the child survey, the Dorber assessment allows us to look at different types of conditions, and there's this marvelous clinical consensus rating, which means we've got a really high level of confidence that people were meeting diagnostic thresholds. One thing is to notice is that using an approach like Dorber, we actually found remarkable stability in the prevalence of mental health conditions in children and young people over time. But this, of course, is the pre-COVID data. Now, of course, we know that there are some children who will experience more than one of these groups. And also there's children who will be experiencing things that are not relevant to diagnostic classification. So we produced another latent class analysis, which drew on non-diagnostic tools, spanning also behaviours, well-being, self-esteem, and also positive indicators like prosocial behaviours as well. Now, what I wanted to do here was just to show that the population profile that we get using different measures, different data sets, different age range is remarkably similar. So on the right there is in the adult data, and on the left is the child typology that I'll talk through now. So around 3/4 of children were in that mentally well group at the time of assessment, but then we see the attention difficulties, emotional difficulties, and that multiple group emerging. So the mentally well group largely, but it's not to say that there's no negative indicators in there, but they don't characterize that group. That attention difficulties group, very high levels of hyperactivity and peer problems, conduct difficulties, but not really characterized by difficulties with low self-esteem or self-harming in the same way. Emotional difficulties, very high levels of low self-esteem. And that multiple difficulties group really stands out, characterized across the board with high levels. This is the sort of chart that we often produce when we're reporting on latent class analyses. What it does is each of these lines represents one of the groups in the population. These are all discrete groups. And we can see that that multiple difficulties group is really characterized by all of them. But if you look at something like low well-being or low self-esteem, things that aren't necessarily part of the diagnostic criteria, we can see they strongly characterize group membership. So if we look at low self-esteem, we found that that was not an issue in our mentally well group, but it dominated. It was a driving factor in identifying young people who were assigned to the multiple difficulties group. Whereas something like hyperactivity characterized both the attention difficulties group and the multiple difficulties group, and self-harming behaviours were elevated in all of those groups, characterised by mental health difficulties, but particularly that multiple difficulties group. Just to say that age wasn't really a factor associated with belonging to the mentally well group or the attention difficulties group. That was very similar in prevalence across the age range that was entered into this. But the emotional difficulties group and also the multiple difficulties group has a strong association with age and is much higher in the older age group. We can then characterize these groups by all of the rich data that is collected in the surveys. So, for example, recognition of special educational needs is much higher in those with attention and multiple difficulties. We've got information in the surveys about parents, so we're able to look at intra-household dynamics, and we can see the strong association with mental health difficulties reported by parents using the GHQ. We can see drugs, sorry, just moving my little thing. We can see that drug use is associated with all of the groups. And school exclusion really is defining that group with attention difficulties. Contact with professional support, as you would expect, is higher in all of the groups characterised by mental health problems, but actually that multiple difficulties group with extremely high levels across all the different indicators, only about half were in contact with professional support services. So the questionnaire has got some really good coverage of support with a wide range of different providers. So in summary, a bit of a whiz through there, amongst 11 to 19-year-olds in England, around 10% show signs of attention difficulties. That's what really characterised their mental health struggles. They're much more likely to be living with parents who are struggling in more deprived neighbourhoods. They're more likely to have SEN recognised by the school and particularly likely to be excluded from school and to experience relatively low levels of both informal and formal support. The emotional difficulties group characterise about 8% of 11 to 19-year-olds within this group. They're more likely to be female, a bit more likely to be older. Socioeconomic disadvantage didn't characterise this group quite as distinctly, so it cuts across the different groups. But we do see particularly elevated use of substance misuse, reported history of trauma and traumatic experiences, and higher levels of support seeking than we saw for the other two groups. But that multiple difficulties group, about 1 in 25 of the population, 1 in 20, slightly older, poorer health in terms of comorbidity. SEN is evident there, much more likely to be living in deprived neighbourhoods with struggling parents, experiencing substance misuse, trauma, low levels of engagement in school, and low levels of support given their high level of need. So it's really, I wanted to highlight this particular analysis just to demonstrate how the data enables you to profile in quite a broad way. So just to say thank you to my co-authors, and just do get in contact with me if you're working with the data and you have questions about what's in there, both the adult survey and the child. And of course, look out on Thursday 9:30 for the next report, and the data will be coming out from that soon.
Brilliant. So that brings us on nicely to the next presentation from Golo Henseke, and apologies if I'm not pronouncing it that correctly. Please correct my pronunciation if it's wrong. Golo is an associate professor at the IOE, UCL's Faculty of Education and Society, specializing in applied economics and quantitative social science. His research primarily focuses on labour market dynamic skills and well-being. And today he'll be talking about revisiting the mental health impact of COVID-19 on young adults in the UK, long-term trends, temporary setbacks and recovery.
Yes, thank you for having me. It's been a fantastic event so far. Let me briefly talk you through our piece of research. I've used our study looks at mental health trajectories of young adults 16 to 29 in our study in the UK from 2001 to 2023. We used data from the UK household longitudinal study, i.e. The Understanding Society, its predecessor, and the COVID study. We were particularly interested on the long-term trends and the specific impact of the pandemic. So we wanted to better understand, so given the long-term trends, how strong was the pandemic impact on this group, and how much and how long-lasting was it? Do we see any scarring? Do we see scarring effects in this data? In other words, did this COVID effect potentially linger on? So the first objective was to examine mental health trends before, during, and after COVID-19, and to use that information to understand the long-term impact of the pandemic on young adults' mental health. And as part of this, we wanted to better understand the influence of survey design differences in existing comparison between the COVID-19 and pre-COVID period. A lot of the conversations, a lot of the research around the COVID-19 impact on mental health for young people comes from the COVID study of Understanding Society. And was a different survey after all, compared then using the same instrument to measure mental health, psychological distress, but it was a different survey. And we were interested, now that the main stage has caught up, how much can we replicate the effects we measured with the COVID-19 study as well with the normal main stage Understanding Society. This work has been, all this work which I'm going to talk about in a haphazard way is published. So if you want to have a look at it, you can just search for this and find it in Social Indicator Research as part of a special issue on the medium and long-term consequences of the pandemic on mental health. Let me quickly give you sort of context where this study is situated in terms of the literature. There's been a number of studies documenting a long-term decline in young people, so specifically subjective well-being in the UK, but also elsewhere. That is evident in lower life satisfaction, increased symptoms of distress, and rise in self-harm. Another strand of the literature clearly shows that COVID-19 worsened mental health, particularly for young people and particularly at the onset of the pandemic. However, that contrasts a little bit with recent meta-analysis of global longitudinal studies found no or only minimal impact pandemic-related mental health effects. And we believe that maybe one issue could be that we switched surveys when we do this comparison between the the Understanding Society main stage and the Understanding Society COVID-19 survey. Even small changes in survey design can result in differences in self-reports of well-being. And moreover, there has been relatively little research into the mental health developments post-pandemic. So we thought of addressing basically two gaps. As I said, we use for our study the British Households Panel Study, the Understanding Society and Understanding Society COVID-19 survey. All these are fully integrated panel studies, which is fantastic. So you can follow people up through the different surveys if they participated in these different surveys and link the outcomes together. What is of note is that Understanding Society, whether as the COVID-19 survey or as the main sheet, was fully online between mid-March 2020 and April 2022, when all the lockdown restrictions came to an end. So all online collection over this period. Our dependent variable is the psychological distress measured by the General Health Questionnaire 12. We use both the Likert scoring and the threshold. In other words, if a person reports more than 3 symptoms on this instrument, would be it would be sometimes defined as a case of psychological distress. Independent variables that we consider age, sex, ethnicity, whether the respondent is in work, number of young children in the household, the income rank of the household, the sample and interview date, and in addition, dummies for the COVID-19 study. Our analytical approach is relatively straightforward. We model mental health as a process that depends on the individual developmental trajectory that's captured through our individual fixed effect and the time trend. Control variables that are life course markers, sort of living as a couple, being in work, parenthood, and survey design effects, which distinguish between the main stage survey and the COVID-19 survey. The pandemic effects are then differentiated between a lockdown and a post-lockdown period. So before I turn to the main results, let's have a look at how different were the responses to the GHQ-12 instrument in the main stage and the COVID-19 survey. These two charts compare these differences, the average differences between these two surveys across age groups by our outcomes of interest, the GHQ-12 sum score, and the psychological distress indicator. And you can see that for both outcomes, the COVID-19 survey reported higher levels of distress. On average, GHQ-12 was about 0.8 higher in the age group 15 to 29, which we're particularly interested in. This shrunk for the 30 to 44-year-olds, and it's about 0.5, a little higher, but it disappeared. This difference between the surveys sort of disappeared in the higher age groups, and a very similar pattern is observed for psychological distress. So in other words, there seems to be some kind of design effect limited to younger age groups, and without adjusting for this, we might overstate the impact of the pandemic on young people. So that was one part of the story. The second part is considering the mental health trajectories before the pandemic. And this is what we've shown in this slide. This is the trend in GHQ-12 scores and the GHQ-12 caseness relative to 2001. Clearly showing that psychological distress in this age group rose already well ahead of the pandemic. By 2019, the mean GHQ-12 score had risen by about 2.9 scores according to our estimates. And self-reported cases of psychological distress were about 9 percentage points above 2001 values, which translates into about 1.1 additional cases, or 1.1 million additional cases of psychological distress per year in this age group. So this is going on before the pandemic. And if we don't consider these pre-existing trends, there's another source that might bias any estimate of the direct pandemic effect if not considered. A few times, the issue of one of the issues with this measurement that's presented so far is that they're self-reported. So what we've done, we've compared it against, we've compared our population average that we get, or that we estimate using the Understanding Society data against NHS reported prescriptions of medicine used in mental health and correlated the trends in both these time series. And we find that in both cases, for the prescriptions are the yellow line in this chart, and the green lines are the trend estimates that we get from Understanding Society. And although they do not look like this fantastic match, they do actually correlate quite highly, these yellow and green lines. The spout is above 0.9 for the mean GHQ-12 score, and is still above 0.8 something for the caseness, which gives us some confidence that these self-reported trajectories do sort of map, or are at least coincide with similar trajectories in prescriptions of medicines used in mental health over this period where we've got the comparable data. So let's have a look at our main results. We split it into 3 models. The first model estimates the impact of the pandemic and post-lockdown period on mental health, given the trend, the pre-pandemic trend, which we controlled for with the cubic polynomial in years. So the comparison is always against that trend. So in other words, model 1 suggests that GHQ-12 was on average 0.95 points above trend during the lockdown period and about trend in the post-lockdown period. But this does not account for the design differences between the main stage and the COVID-19 survey. If we take into account the COVID-19, if we take into account and control for the COVID-19 survey, this lockdown period, the lockdown effect reduces to 0.5. And we even end up with a slight below 0 post-lockdown estimate here. We used, to adjust for the design differences, we used dummy variables. One should say Understanding Society warns against using dummy variables to deal with potential mode effects. So what I've done in column 3, I dropped the COVID-19 survey entirely and just used the main stage information, finding basically the same effect of the lockdown period and post-lockdown period on mental health. Obviously, or the lockdown period, and I should have said, was defined as the whole period between the second calendar quarter of 2020 to the end of the first calendar quarter of 2021, and the post-lockdown period was 2021, second calendar quarter of 2021 to the first calendar quarter of 2022. And these are broad periods. There was a lot of change in policy over these periods, different lockdown periods, and so forth. So the next thing we've done, we unpicked these trajectories a little bit and tried to tease out basically doing an event study of how did over this period, within this period, mental health change. And we see in the first chart, well, it sort of immediately jumped, mental distress jumped up immediately with the lockdowns. It sort of stayed stable over this lockdown period, increasing further in the first quarter of 2021, coinciding with the third national lockdown at that particular period, before falling back to the trend, to its trend prediction straight after lockdown restrictions were lifted. We see a very similar picture for the caseness indicator. Psychological distress rose with the onset of the lockdown, then it eased a little bit off and jumped up again with the lockdown, with the third lockdown, before coming back, recovering to trend values. So let's put this into perspective. One of the issues, or one of the concerns, was particularly basically from the onset. There was hypothesis and evidence that young people were particularly hard hit by the pandemic. And some of this evidence that came from this comparison of the Understanding Society main stage with the Understanding Society COVID-19 survey. But if we account for the design effect differences and compare the age effect during lockdown and post-lockdown on either our outcomes, we do actually see that we don't actually see age differences in how lockdown and post-lockdown related to mental health outcomes across the age groups. We did a number of robustness checks, looked at alternative measures, checked for panel attrition, we used alternative time trend specification and did a placebo test, and none of these robustness checks invalidated any of the findings that I just presented. So the key findings coming from our analysis that the pandemic effects must be viewed within a broader context of more than 2 decades of increasing psychological distress. The pandemic accelerated but did not cause a lasting increase in young adults' psychological distress. Young adults showed resilience, with most mental health impacts of the pandemic being short-lived on average. It's the underlying long-term issues that need to be addressed. And that's it from me. Thank you.
That brings us on nicely to our next presentation. Thank you very much, Golo. So next we have Claire Wicks. Claire Wicks is a senior research officer in the School of Health and Social Care at the University of Essex. Claire's postdoctoral research is funded by the NIHR, National Institute of Health and Care Research, East of England Applied Research Consortium, and her research focuses on exploring mental health inequalities in the UK through the lens of diagnosed and undiagnosed mental distress, using data from the UK Household Longitudinal Study. And today she'll be presenting on the risk of diagnosed and undiagnosed mental distress in coastal and inland UK adult residents. So I see you've already got your slides presented. Please feel free to start.
Okay, so first of all, I'd just like to acknowledge my co-authors on this research, Professor Susan McPherson, Professor Meena Kumari, Dr. Karabukar, Dr. Antonella Trotter, and Dr. Emily Murray, all from the University of Essex. So the recent focus on coastal communities has been driven by the findings of the UK Chief Medical Officer's 2021 annual report that highlighted the inequitable health outcomes of coastal compared with inland residents in England. In addition to a range of physical health conditions, the report identified worse mental health outcomes for coastal residents. It also identified increased risk of mental health burden for coastal youth, with a 35% higher risk of hospital admissions due to self-harm in 10 to 24-year-olds relative to non-coastal youth. So the CMO findings were based on data submitted by GPs to the General Practitioner Quality and Outcomes Framework, and therefore did not take into account those who may not have sought support for their mental health from a GP. And this is estimated to be as many as 2/3 of adults experiencing a common mental health disorder. In 2024, Murray et al. Explored health outcomes in coastal communities using population data from Understanding Society, and found that coastal effect for mental health was only evident in those who grew up in the 20% most deprived coastal areas of England. And this indicates that deprivation plays an important role in coastal health outcomes. So to further explore the coastal mental health, we wanted to ask whether risk of diagnosed and undiagnosed mental distress differs between English residents residing in inland or coastal areas, whether deprivation is associated with risk of diagnosed mental distress, whether compositional factors explain risk of diagnosed or undiagnosed mental distress, and whether risk of undiagnosed mental distress differ across stages of adulthood. So to explore this question, we drew on a sample of 28,549 adult respondents across waves 10 to 13 of the UK Household Longitudinal Survey. And we used respondents' most recent response between waves 10 to 13, with data collected between January 2018 and May 2023. We completed our analyses in Stata version 18 using multinomial regression, where coastal status was our independent variable and mental health status was our dependent variable. We also included covariates of age squared to allow for nonlinear relationships, area deprivation, which was measured using the Townsend Index ONS quintiles, and the Townsend Index is based on 4 census variables: unemployment, non-car ownership, non-home ownership, and overcrowding. We also controlled for sex, ethnicity, net income, which was adjusted for household composition and inflation, and tenure. So we used the UK HLS cross-sectional adult self-completion weights and adjusted for clustering by lower layer super output area. And our statistical output were relative risk ratios and 95% confidence intervals. So to define coastal community status, respondents were dichotomized as either coastal or inland residents. We did this using the 2011 lower layer super output area codes of respondents, which were obtained under a special user license agreement with Understanding Society. The LSO codes were cross-referenced with the area classifications of inland or coastal provided in the CMO's 2021 report. And within the report, coastal LSOAs were those that included or overlapped with built-up areas which lay within 500 metres of the mean high water mark, excluding tidal rivers, which basically means any settlement along the coast. So then thinking about how we find undiagnosed mental distress, we drew on 2 variables from the Understanding Society datasets. Self-report mental distress, which was measured using the General Health Questionnaire, the GHQ-12. And for our analyses, we used the caseness scoring method, which ranges from 0, the least distressed, to 12, the most distressed, with a score of 4 or higher indicative of potential mental distress. In addition, the UKHLS asks in the adult questionnaire about history of mental health professional diagnoses, where a response of no indicates no diagnosis has been received. Therefore, a GHQ-12 score of 4 or above and no history of professional diagnosis was used to identify respondents potentially experiencing undiagnosed mental distress. So in total, we derived 3 mental health categories: no treatment need, which were respondents with a GHQ-12 caseness score of less than 4 and no history of a mental health diagnosis; undiagnosed mental distress, respondents with a GHQ caseness score of 4 or above and no history of mental health diagnosis; and participants diagnosed mental distress, and that's those with a GHQ-12 caseness score of 4 or more and a history of mental health diagnosis. So just a snapshot of our participant demographics here. So the sample consisted of around 5 times more inland residents compared with coastal residents. The characteristics of inland and coastal residents were similar. However, we do know that the coastal communities have a slightly larger population of older adults, which is those aged 66 years and older, and a much larger population of white British respondents. So going on to our analytical models and findings. So in our first model, we included coastal status as our independent variable, age and age squared as covariates, and mental health status as our dependent variable. So we found that coastal study members had a 19% higher risk of having a diagnosed mental distress than inland study members. However, there was no association between coastal residents and undiagnosed mental distress. However, descriptive data did reveal that 17% of inland and 15% of coastal residents were living with undiagnosed mental distress. So this highlights that actually quite a large population of English residents are living with an unrecognised mental health need. In our second model, we added area deprivation as a covariate and also coastal status by area deprivation as an interaction term. And our results revealed that participants residing in the top 20% most deprived coastal areas had a 75% higher risk of experiencing diagnosed mental distress compared with those who reside in equally deprived inland areas. And this very much supported previous research indicating that the coastal effect for mental health is only replicated at the population level when examining coastal effects by strata of area deprivation. So in Model 3, we also added income, ethnicity, tenure, and sex as covariates. And after controlling for these socio-demographic variables, there were no associations between coastal or inland residents and undiagnosed or diagnosed mental distress. And this could suggest that the coastal effect is explained by other variables already known to be associated with mental health, which of course income, ethnicity, tenure, and sex have been. And then finally, we conducted some subgroup analyses by age category. So we had younger adults who were aged 16 to 24 years, working age adults who were 25 to 65 years old, and older adults who were 66 years and older. So we found that the young adults residing in the top 20% most deprived coastal areas had over 3 times higher risk of undiagnosed mental distress compared with equally deprived inland residents. And then in contrast, we found that older adults residing in the top 20% most deprived areas experienced 1/3 of the risk, so a reduced risk of experiencing undiagnosed mental distress compared with equally deprived inland residents. And we did wonder if the opposite associations found in younger and older adults might explain the non-significant results from previous models, as these relationships may have effectively cancelled each other out. So this graph shows the findings for the subgroup analysis for young adults. Area deprivation is along the x-axis, represented by the Townsend index quintiles, and predicted prevalence on the y-axis. So the green line shows the prevalence of undiagnosed mental distress in coastal young adults, which we can see increases steeply in the most deprived quintile relative to the other groups. And if you can't quite see the legend at the bottom, the yellow line is prevalence of diagnosed distress in coastal young adults. The blue line is undiagnosed distress in inland young adults, and the red line is diagnosed distress in inland young adults. So then thinking about what is potentially driving the increased risk of undiagnosed mental distress in the most deprived coastal young adults, research has shown that there's a lack of hope and prospects for the future, which may be due to poor educational outcomes and employment prospects. Coastal young adults can also feel marginalised by their own communities. This can include feeling unsafe in public spaces and towns tending to prioritise amenities for tourists rather than the local young population. There are also barriers to migration inland, which may result in young adults feeling stuck. And barriers may include economic, cultural or social resources. And then finally, the closure of youth mental health services nationally has resulted in considerable shortfall in services and adolescents potentially moving into young adulthood with poorer mental health. Coastal adults may also experience greater barriers when attempting to access mental health services, for example, because of poor transit links and a smaller pool of accessible services compared to inland young adults whose direction of travel is not restricted by the coast. So in terms of our recommendations, in the short term, we recommended that investment in delivery of interventions to support the mental health of coastal young adults in the most deprived areas. This should include facilitating access to services with a focus on the most at-risk groups. This might include how services can be brought closer to coastal young adults and how barriers can be overcome, for example, harnessing digital solutions. At a national level, the government should reinvest in youth mental health services, which have been dramatically reduced in recent years. And mental health care policy should insist on joined up working between adolescent and adult mental health services for continuity of care to protect young people from falling victim to the service gap when moving between adolescent and adult services. In the long term, we recommend investment in deprived coastal communities to tackle the drivers of poor mental health. This includes improving opportunities for education, employment, housing and social connection, with improved public transport essential for all. And investment should be considered on an individual basis with the needs and assets of each community at the heart of developments. So new opportunities shouldn't threaten existing income streams, opportunities for health or the natural environment. So, for example, wind farm developments offer opportunities for unemployment, but can also damage or reduce access to the local natural environment and or affect tourism and fishing industries of coastal communities. Some references, and thank you for listening, and I'd be happy to answer any questions.